Mike Gibson, Paul Ridker coming to you live from UC 2024. Paul, you have some hot new data coming out on 30 years of follow-up looking at LDL, CRP, LP(a). Excited to see what you found.
Yeah, thanks, Mike. It's always great to join you, and it's wonderful to be at the ESC presenting these new data. As you know, we've spent 25, 30 years trying to figure out how to better predict heart disease and how to focus on what I think are the modifiable risk factors. That's why we really are focusing here on LDL, because we all know it should be low. High sensitivity CRP, our marker of inflammation, because we now have randomized trials saying we should lower that. And we focus on lipoprotein(a) because we have drugs that can target this, and we'll know within a year or two whether or not it actually lowers event rates. So this was very specifically focused on women. So this data comes from the Women's Health study that my colleague Julie Buring has run out of our offices at the Brigham for the last 30 years. We had a random single blood sample obtained between 1992 and 1995. That blood sample was assayed for high sensitivity CRP, for LDL, and for LP(a) using state-of-the-art assays. And we literally have followed these women for a full 30 years. And Mike, I got to tell you, the results are really impressive. A single random blood draw. HSCRP is the strongest of the three predictors. Hazard ratio of the top quintile versus the bottom about 1.7. LDL looked pretty good, about 1.4, and LP(a) about 1.3. Of course, with LP(a), the risk is entirely those with the highest levels, because as we all know, it's really a genetically determined risk factor. But the real kicker in this thing was we looked at this in terms of adding things together, because again, it's not about what's necessarily best, although obviously when inflammation is best, it makes me happy. But it's really about thinking, why aren't we measuring LP(a) and why aren't we measuring CRP if we have universal guidelines saying we should measure LDL? And so we added these together and found that if you take any combination of these, you do very well. They're completely independent of each other. And if you actually sort of say simply, well, what was your risk if you were, say, in the top quintile of all three versus two of the three versus one of the three, you get very direct hits on risk, both for total MACE, for coronary heart disease, for stroke. And it's also a little bit daunting to watch these survival curves. These aren't 5 and 10-year curves. These are 5-year, 10-year, 15, 20, 25, 30 years. And Mike, the rates just keep going up and up and up. That's actually part of the message here. We've all watched our colleagues at the guidelines struggle with 5 and 10-year risk. Every preventive cardiologist knows we have to start much earlier in life and really address this very aggressively. In women in particular, we have a problem. No surprise to you, but coronary disease remains underdiagnosed and undertreated in women. So the NIH has some real interest here. And by the way, this was entirely funded by the National Institute of Health. But I think, Mike, at the end of the day, what these data are telling us is we need to rethink the whole structure of screening and prevention. Now, let me actually push this a little bit for you if I can. This is a primary prevention study, but it's identical to a host of secondary prevention studies that we published in the last couple of years, and you and I discussed the last time we did this, both for the ACC and the AHA, where we showed that of these biomarkers, CRP was at least as good as LDL. And that's now true not just in secondary prevention, but in primary prevention. So I think we have to start asking ourselves, why aren't we measuring inflammation as often as we're measuring LDL? LP(a), of course, is very interesting because we're going to have trials very soon. And if that's positive, I'm sure we wanted to screen LP(a). But these are modifiable. And the idea that we can look at 30-year data and think about, well, what's going on here is really the big issue here. Like I've said this before, and you and I have talked about, is you can't treat what you don't measure. And until we start measuring the biomarkers that actually matter, we can't really beat this disease. So we're pretty excited about the data, and we hope that it'll have some impact, particularly if we're trying to understand universal screening and when are we going to actually shift how we do prevention and start to move towards what can we modify? Not simply, here are some risk markers that tell us, what your risk is, and not simply saying low, medium, or high, but hey, lower is better for all three of these probably. We really ought to be taking that into account.
So lower is better, but with 30 years of follow-up, it begs the question, is earlier better? We've begun to think about the concept of cholesterol years. I think someday we might talk about BMI years, all of these things are cumulative over time. So Paul, with a 30-year, snapshot in front of you now, is it time to move also towards earlier is better?
Well, Mike, it's actually the very important question coming out of this beyond the raw data themselves. I need to tell you a little about the cohort to answer your question. The women's health study was purposely designed to be female health professionals. So these are pretty well-off women in general. They're registered nurses, they're LPNs, they're dental hygienists, there's some fraction are physicians. And that's important because it meant they had high access to care and certainly good access to healthcare and certainly knowledge of healthcare. Now, in 1992, in primary prevention in women, basically 0% were taking a statin. But halfway through this 30-year cohort, at year 15, we start seeing statins being prescribed. And by year 30, more than half of these women are on a statin. Now, I think that's pretty good. But Mike, if I could show you the curves, which is hard to do over the Zoom like this, there's no inflection. It's not like the LDL curves or the CRP curves or the LPLA curves changed by adding all that statin therapy. Now, we know the risks came down 20, 25%. But this gets back to your fundamental question. Why did we wait until these women were in their late 60s and 70s to start statin therapy? Well, we did that because that's what our guidelines tell us to do. To get a woman
Right.
with a high enough risk above to treat, you got to be pretty old. And what we're also saying here is I suspect that statin therapy alone is not going to be the end all and do all. It's the bedrock that we all do past diet, exercise, and smoking cessation. We know that. But when you look at these curves, I thought we'd see an inflection. I thought we'd see some flattening of the curve. It's not happening. In fact, if anything, like what's happening is as these women age, perhaps not surprisingly, the curves start to stratospherically go up higher and higher. These women are now in their early to mid 80s because they started out in their early to mid 50s. And particularly for stroke, Mike, these curves are just shooting up and up. So I think you're right. I think we have to start earlier. We have to be more aggressive. We have to think about what's our next intervention going to be past that statin? Would it be an anti-inflammatory drug? If the CRP is high, will it be an LPA drug? If the LPA turns out to be high and the trials work,
Or a polypill of all of the above.
Or yes, or a polypill of all the above. And again, hypertension's got to be dealt with. There's a lot of meat here that has to get absorbed by the prevention community, and I think it's going to be fun to walk that through.
Well, great things take a lot of time. You've been at this CRP hypothesis for a few decades now. It's great to see all this playing out. I was asked a little while back, what's the key to a successful research career by young people? I said, persistent, staying at it for decades. And, I said, you do something good today, nothing good's going to happen today. It takes years. So congratulations on decades of work in this area. It's starting to pay off where we can really see all the fruits of your labor. Thanks, Paul. And thanks to all of you for joining us here live from ESC 2024.
My absolute pleasure, Mike. Take care.
Mhm.